Thank you, Anupama ma'am, for giving me the opportunity to speak in this conference. And I joined actually late, but I was fortunate enough to hear talk by Dr. Madhusudan, the excellent talk. And in fact, he has made my work actually easier by talking about the PARP and everything and ovarian cancer. So I will just quickly brush through the ovary part and would take some time in the endometrial part. So I'm a medical oncologist, a clinical person, and here we have the habit to actually take advantage of the excellent work done by all the translational researchers, as Dr. Madhusudan and others are doing, and try to apply to the to our patients. So I'll just start with my talk and. Sorry. So I start with ovarian cancer. We all know about the epidemiology and everything. The bad thing about ovarian cancer is it is really lethal, and the mortality is very high. Mortality and the morbidity are very high in ovarian cancer. So unfortunately, majority of them they present at advanced stages. Previously, and when I was a trainee at Tata, also the standard of care used to be surgery and neoadjuvant or adjuvant chemotherapy. So at that point of time, the debate was whether we should give neoadjuvant or we should just do the primary debulking surgery and give adjuvant. So we only had these things available, and only surgery and chemotherapy were the mainstay of treatment. And median PFS used to be, in fortunate enough, patients up to 18 months, but quite a few patients even relapsed before 12 months period. But what Dr. Madhusudan has just told us, and what has happened in the last decade, insights into the homologous recombination repair, they have actually changed the way. Now we look at ovarian cancer. Now we treat, or the way we treat ovarian cancer now. And I would not go into these details. Dr. Madhusudan had already, highlighted very nicely about the concept of synthetic lethality, the concept of the double-stranded DNA repair or single-stranded breaks, and etc. What I would highlight here is a certain few points. We know the synthetic lethality thing. I would not repeat that. I would go for all the clinicians. Sometimes we get confused with the terminology. So I would take a moment to explain the terminology we use in our clinical settings when we are trying to evaluate patients for ovarian cancer. So these are certain terms which are now repeatedly used when we are reading trials or we are treating ovarian cancer patients. One is HRR, which is just an important error-proof DNA damage repair pathway, and research into these pathways, the defects in these pathways have led to a lot of new insights. So, what do you mean by HR proficient cells? That means these cells are able to repair DNA damage, especially the DNA double strand breaks by homologous recombination repair pathway. What do you mean by HRD? That means they have a deficiency of this homologous recombination repair pathway, and these are the tumors of interest where PARP inhibitors have shown some difference. So HRD positive means we have done a test and it has came out to be positive by some assay like a myriad assay or a LOH assay by foundation, and the test is positive means there is a defect in homologous recombination repair pathway, and negative means the test says that there is no defect. So this terminology is sometimes very a bit confusing. So I've just included that. Now, there's also a bit of sometimes there's a bit of confusion among clinicians to understand the difference between HRR and HRT. So HRR actually means that there have been certain mutations, or there have been mutations which have the capability to cause a deficiency in homologous recombination repair. So HRD means it's a consequence of deficiency in HR, and causes of deficiency are mutations, germline or somatic, and the consequences we look at by seeing at mutational signatures or by genomic scars or genomic instability. So what does HRD test do? It tries to find out a HR deficiency, regardless of its etiology or mechanism, with utility across different tumor sites. So, and here comes the concept of genotype versus phenotype. And so, genotype is something, mutations in HR genes are not the only cause of HRD. So, that's why the test of HRD is more important than just checking the mutations of HRR pathway. So there are certain other mechanisms that can lead to HR deficiency, and that like MRI, microRNA regulation and differential expression, and they also may lead to HRD phenotype. So a patient may test positive for a mutation in HR pathway gene like PALB2 or CHEK or RAD, but may not have the HRD phenotype, which is important for us to find out. Then patients, so that's why it's the phenotype which is of interest to us rather than the genotype, and that we get to know by understanding the genomic scar scores or genomic instability scores or other mutational signature. So this is one of the common assays used for HRD, which looks, and Dr. Madhusudan also touched into this, that they look at loss of heterozygosity and telomeric allelic imbalance and large-scale state transitions. All these things are caused by certain alterations, either mutations or RNA dysregulation, and they lead to a genomic instability in the tumor, which is picked up by these tests, and we call it a GIS, a genomic instability score, which vary according to the test we are doing. This was the original test described, where they use 42 as the threshold for being HRD positive. And we also know that it's why it is important to check for both BRCA mutations in the blood as well as in the tissue, because we can find up to 50% of the patients we can find who have some kind of HR deficiency, either because of BRCA or because of other mutations or other mechanisms. So these 50% of patients are those who can actually benefit with the addition of certain other therapies. So why HRD? Because if we just do an HRR mutation, we will just pick another 7%. But if we do HRD testing, we will pick another 19% apart from BRCA mutated patients. It is both a predictive and prognostic biomarker. I will not go into detail of this. I'll just come directly to PARP inhibitors. Dr. Madhusudan already touched into this. We know olaparib, niraparib, rucaparib. We have a lot of data with all these PARP inhibitors, but they have really changed the way we are treating ovarian cancer now. And the notable trials were Solo 1 was the trial where olaparib was compared to placebo in BRCA mutant population. Prima used niraparib in all comers actually. Paola 1 added bevacizumab to a PARP inhibitor, olaparib. Velia used this veliparib, and Athena mono used rucaparib. And Athena mono and Prima were used in all comers irrespective of HRD or BRCA mutations. So, and the results were very clear, at least in BRCA mutant, significant, very significant PFS benefit, which was unheard prior to that. You see, the median PFS 13.8 months with placebo, but up to 6 months with PARP inhibitor. This is the difference which PARP inhibitors can make, especially in BRCA mutant population. If we talk about BRCA wild type but HR deficient, again there is a benefit, though not as stark as in BRCA mutant, but yes, still the magnitude of benefit is enough for us to think over and give PARP inhibitor to these patients also. And that underscores the importance of HR deficiency test and not the HRR test, which is sometimes commonly done in ovarian cancer patients, but that doesn't predict the benefit. The benefit is predicted by HR deficiency. So now, why we are worried when there was a benefit in even in the HR proficient population, which I told you is the one in which the homologous recombination pathway is unaffected. The importance here is the magnitude of benefit. If you see the magnitude of benefit in BRCA mutated and HRD positive population, it was much more than as compared to those who are HR proficient. Only 3 months PFS benefit was there. So now after Prima niraparib and after Prima, this niraparib was approved in all comers, even in HR proficient population. But we all know as clinicians that that possibly the risk versus benefit ratio may not be that optimum in those who are HR proficient. And this is just there was a meta-analysis from Tata which looked into this fact, and they devised that, so they found out that in HRT negative population, there is not much benefit of giving PARP inhibitors, and that underscores again the importance of finding out the patients who have HR deficiency. So niraparib is approved for all comers. Rucaparib also showed a 3-month benefit in HR proficient, but as of now, and as far as I know about the clinicians in India, we are not using PARP inhibitors in HR proficient population. So that was another point, and I want to add here. I haven't got the slide of that, which Dr. Annapurna asked from Dr. Madhusudan about the role of immunotherapy in ovarian cancer, and he pointed out that so far we haven't been able to find any benefit of immunotherapy. There has been a trial, in fact, of immunotherapy in combination with rucaparib. It was another arm of Athena trial. It was called Athena combo, and they found out that when nivolumab was combined with rucaparib versus rucaparib alone, there was no additional benefit. So there also, so the question that was asked was whether addition of immunotherapy can help ovarian cancer patients when PARP inhibitor is being given to them. So far, that it's available in the abstract form, and it says that no, even those who are getting PARP inhibitor, if we add immunotherapy, there is no additional benefit. So that was about the use of PARP inhibitors. But it's not only the PARP inhibitors which have been helpful. Angiogenesis. This came way before the PARP inhibitor thing, and this is one of the hallmark of cancer, and we have and the researchers have used that in finding out treatment for ovarian cancer patients. And angiogenesis, which is defined as formation of new vessels, we all know that, and it is mediated by VEGF. And this is one of the important mechanism or hallmark of ovarian cancer pathogenesis also. Additionally, there are it may also be involved in conferring platinum resistance. So this was taken to advantage by some people, and there is a concept here. Not many in world use oral metronomic chemotherapy, but we being a resource constrained setting, we have been exploring oral metronomic chemotherapy, which is actually giving low dose chemotherapy continuously with very small breaks. And the mechanism by which they work is two important. One is anti-angiogenic, second is immunomodulatory. Cytotoxic action is actually a bit less. And this fact that there is angiogenesis involved in ovarian cancer and also in other cancers, we have taken that to advantage, and we did a study here where we compared addition of an anti-angiogenic inhibitor, pazopanib, to a combo of oral metronomic chemotherapy, and we found out that adding that anti-angiogenic therapy, in fact, improved the PFS. And let me tell you, quite a few patients we are here, when they are not able to tolerate cytotoxic chemotherapy, we offer them this oral metronomic chemotherapy, and they have a decent quality of life and good tumor control also. So that's again something, when we look into molecular biology and we apply that to the clinical aspect, these things we get, and we have been able to really take to that our advantage. That was oral metronomic chemotherapy that took advantage of angiogenesis, but we all know about the drug bevacizumab. It is a VEGF, it binds to the circulating VEGF and inhibits the binding of VEGF to its cell surface receptor. And we all know bevacizumab has been used in ovarian cancer in platinum resistant setting. Aurelia trial proved that. in also in platinum sensitive setting. The trials I haven't included the trials. They were Oceans and in the recurrent setting, and Icon and GOG trial in the primary setting. Notably, none of these trials have actually shown an overall survival benefit. Only a ad hoc post hoc analysis of Icon 7 trial showed that bevacizumab, when used in stage 4 ovarian cancer or suboptimally resected ovarian cancer, had a small survival benefit. Still, a lot of clinicians use bevacizumab in upfront therapy, some use in recurrence. But what I know from my experience is it is most useful when it is platinum resistant. And two important point here is that anti-angiogenesis is also involved in when the patient develops platinum resistance. Secondly, angiogenesis is also involved in the development of ascites and effusion. These are also the patients who notably derive some benefit from bevacizumab. So moving from ovarian cancer to the standard ovarian cancer to another variety which is less common but chemo resistant variety. Now still the standard of care includes surgery as well as common chemotherapy which we use paclitaxel carboplatin as of now. But this has a different biology from high grade serous and other type of ovarian cancer. They tend to be chemo resistant, but molecular insights into this cancer is also helping us to find out new therapies for ovarian clear cell carcinoma. Not as of now standard of care, but we have seen that ARID1A mutations are quite common in ovarian clear cell carcinoma, and when ARID1A is present, there is more mutational burden in the tumor. These cells also tend to have a MSI high status, and hence there is some data that they derive benefit from use of immunotherapy. So it is not standard of care, but we have used that in few patients of ovarian clear cell carcinoma in the recurrent setting, and patients have derived good remission. MSI high, definitely a very good remission. Only ARID1A also derived a decent remission with the use of immunotherapy. So I would end with ovarian cancer here and then move to endometrial cancer, which has also changed the paradigm shift in how we see endometrial cancer. Again, during my training when I was in Tata, there was a different way we used to look at endometrial cancer, but now it has evolved significantly. So the main things which we look at endometrial cancer to find out how they can benefit from any adjuvant therapy are using the stage, histology, grade, and now we use molecular markers. This classification, which was a simple type 1, type 2 endometrial cancer, we all know type 1 is the one endometrioid type associated with obesity, low grade type. Type 2 used to be the high grade, serous one. This was the when I was in training, but now it has evolved significantly. And now we know after people have looked into the molecular signatures, we have 4 different classes, and they have actually changed how we treat endometrial cancer now. The one is POL mutated, MSI high, and CN low and CN high. So what has changed because of this classification is that now we have 4 different groups. Either we have a P53 abnormal group, or a polymutant, or a DMMR, or no specific molecular profile. I'm sure somebody must have talked about this, but look at the difference in prognosis of the outcomes of these 4 different types. So the straight line is for polymutant. They have a very excellent outcome. Why they have this excellent outcome is because it induces a hypermutated state. There are more new antigens, and the body's immune system is very effective in clearing these cells. So on the bottom is the P53 abnormal, which we know are actually high grade. They are kind of serous type, and behavior is sometimes like ovarian high grade serous carcinomas. So now the prognostic system has changed. Now how we look endometrial cancer has changed, and how we treat has also changed. How now there are new guidelines which have previously the risk stratification of endometrial cancer used to be based on stage, on LVSI, on myometrial invasion, and certain and age also they were used. But now after this molecular classification, it has altogether changed. It is now advisable to do molecular testing in all endometrial cancer patients, specifically those where molecular testing will change the treatment. Now, look at these polymutant. So if the patient is polymutant, and even if it is at a stage 2 or something and is falling into a higher risk group based on the previous classification, but polymutant are so well, they behave so well that now stage 1, stage 2 up to polymutant, they are considered low risk, and you can just observe them after the surgery. There is no need of any adjuvant treatment. So where is adjuvant treatment required? Where do we tailor our where do we use chemotherapy actually? Is in this only high risk group, which comprises of P53 abnormal with myometrial invasion patient. And mind it, P53 abnormal should be present alone. There is a concept of double classifiers here, that if polymutant is present with P53 abnormality, that is a double classifier, but in this, usually P53 abnormality is considered a secondary genetic event and is counted as a passenger mutation. So if both P53 and polymutant are present at patient stage 1 or 2, we will observe the patient, but if it is only P53 abnormal and there is some myometrial invasion, that will be considered as a high risk, and we need to give them adjuvant chemotherapy as well as radiotherapy. Otherwise, if and another point here is if P53 abnormality is present with MMR deficiency, then also P53 will be considered as a secondary genetic mutation, and we will treat the patient. We will classify the patient among these low intermediate or high intermediate groups, looking at MMR deficiency. So it will fall somewhere here in the high intermediate group. If they are stage 2, yes, we all know that stage 3 and stage 4 are highest, irrespective of their molecular signature. But if they are stage 1 and 2, then molecular signature will determine what will be the risk stratification and what will be the adjuvant treatment. So in the adjuvant therapy, that way now we are deciding, doing the molecular profiling, and then where the patient falls, in which group it falls, and that determines the adjuvant treatment. So, so what has actually changed? The two things that have significantly changed is a finding of a group of polymutant which have extremely good prognosis, and this has probably saved a lot of patients from toxicities of adjuvant treatment. There is also now quite a bit of data coming up that probably even the stage 3 polymutant patients can now be observed. However, this is still not the standard of care, and the studies are going on to find out what to do with the stage 3 polymutant patients. What MMRD has given to us is the immunotherapy. Dr. Madhusudan also touched into that, and these are the patients who have derived a lot of benefit with the immunotherapy, not only in endometrial cancer, but it's kind of a tissue agnostic thing. Any solid tumor with MMR deficiency, they derive a very good benefit from immunotherapy. So where we stand with immunotherapy in endometrial cancer. So these two landmark trials have changed the way we now treat endometrial cancer in mainly in the recurrent setting, but sometimes in some cases in the primary setting also. The two immunotherapies which have been studied are dostarlimab and pembrolizumab. The trial for the I'll be discussing. This is the NRG-GY018 scheme. It randomized patients of stage 3, 4A with measurable disease or recurrent endometrial cancer to two arms. One received standard adjuvant chemotherapy, and in one pembrolizumab was added and then used as maintenance. And you see the separation of curves in the TMMR cohort. They start separating very early, and there's a stark difference when immunotherapy is added to patients who have a deficient MMR in their molecular signature. And this has changed the way we are treating endometrial cancer. Now we are offering immunotherapy, especially in recurrent setting. If they are chemo naive, they haven't been treated with chemotherapy so far, and if they are DMMR, we add we add immunotherapy along with chemotherapy, and then use immunotherapy in as maintenance. There was a benefit in PMMR cohort also. Again, there was a separation of curves. There was a benefit, but we are a little skeptical about whether we'll see a OS benefit in this population or not. So we are still not very comfortable in using immunotherapy in a PMMR cohort. So Ruby trial, it was similar to the Pembro trial. In this, instead of Pembro, dostarlimab was used, again added to chemotherapy and used as maintenance. Again, you can see the stark separation of curves when immunotherapy was added in DMMR population. And they behave very nicely. You can see the HR 0.28 significant difference between the outcomes. And dostarlimab is not available in India, but it is now recommended in this group of patients. Again, in the PMMR cohort, the benefit was not that stark, and we are still waiting for OS data to mature, and based on that, most likely we'll be deciding whether we'll be using immunotherapy in PMMR population of endometrial cancer or not. So these are and another thing was that irrespective of the histology, these patients derived a benefit. And important is the DMMR signature. If it is present, the benefit was quite stark. What about the molecular classification in these trials? They were represented by all groups, but if you see the dissection of this trial, when we looked into the molecular classification, see the polymutant patients behave more or less similar, even if immunotherapy was used or not. And the reason for this is the exceptional prognosis of polymutant patients. So much hypermutation in this that there are a lot of new antigens, and their prognosis is actually very good. But if we look into the biology, into how immunotherapy access, they actually need a lot of new antigens. Even if the polymutant relapses, there is a lot of biological evidence, you can say, to treat this patient with immunotherapy. They are likely to benefit with immunotherapy as the DMMR cohort, but that data is still evolving. We don't know. Polymutant are so well that the relapse rate are very minimal in the polymutant population. Again, we can see the maximal benefit in the DMMR cohort, and no specific molecular profile, and TP53 mutation derived less benefit with addition of immunotherapy. Based on this, now the guidelines have changed, and they are including immunotherapy in the treatment armamentarium of endometrial cancer in the recurrent setting, and in the primary setting if they have any measurable disease after surgery. So, what is next? What is coming next in endometrial cancer is this clinical trial program where they will be tailoring treatment based on the molecular classification. P53 will go to one arm, and they are also looking into HR deficiency as in ovarian cancer, specifically in P53 abnormal patient. They are trying to add olaparib also. In MMR deficient, they will add immunotherapy. Non-specific molecular profile will go to standard of care, which we have always been using, chemoradiotherapy. And polymutant, they are trying to de-escalate now. Probably will have data in a few years down the line that polymutant, irrespective of stage 1, 2, or 3, it can be observed. So, just concluding what I have told you so far in this talk is, Adjuvant treatment of both ovarian and endometrial cancer has evolved from chemotherapy only in the past to now chemotherapy plus targeted or immunotherapy. Now the backbone remains chemotherapy, but molecular profiling has now become essential to tailor your adjuvant treatment and add targeted therapy or immunotherapy, targeted therapy in ovarian cancers and immunotherapy now in endometrial cancers. And here I end my talk. Thank you very much for the patient listening and giving me the opportunity. Any questions are welcome. Thank you.